Thank you very much, everyone. Welcome to the presentation for this afternoon, which once again is on the topic of clinical pharmacology. So we've already had a presentation on clinical trials. Today, the aspect of clinical pharmacology we're going to be covering is therapeutic drug monitoring. So we have two presenters. Our first presenter is Professor Betty Sallustio, who runs the Queen Elizabeth Clinical Pharmacology Lab. And her topic today will be measuring drug concentrations, changing clinical outcomes. Just before we start, I just want to encourage our members to use the Q&A section of your Zoom window. We'd also, of course, should acknowledge the traditional custodians of the land and pay respects to their elders past, present, and emerging. And just a reminder that this session is being recorded and you can access the recording afterwards. So over to Betty.
Thank you. So I thought I'd just give a really broad overview of our laboratory functions, and in the hope that we can start some new collaborations with clinicians and researchers at CALHN and at the Adelaide Biomed City precinct. And as you can tell by my title, we spend a lot of our time measuring drug concentrations in patients so we can improve clinical outcomes. So our laboratory carries out therapeutic drug monitoring, and that is a form of personalized medicine that strives not just to prescribe the right drug for a patient, but also the right dose. And I'd like to give an example of one of the drugs that we monitor, Tacrolimus, which is an immunosuppressant used to prevent rejection in organ transplantation. So in renal transplantation, the area that I'm most familiar with, patients start Tacrolimus within 6 hours of their transplant surgery, and they're all administered 0.05 milligrams per kilogram of an oral tablet twice a day. But maintaining patients on this same dose is not possible because there would be too much variability in patient response. This is because the fraction of that tacrolimus dose that reaches the circulation varies significantly between individuals. So there would be many patients who would have low exposure in their circulation and would be subject to rejection and damage of their transplanted kidney. Similarly, there would be many patients who would experience high exposure and so be at risk of tacrolimus toxicity, which paradoxically includes nephrotoxicity, and so would also be subject to kidney damage. So TDM allows us to individualize dose for each patient by targeting the same exposure in blood or plasma. So this pharmacokinetic variability can arise at any step in the process of drug absorption from the gastrointestinal tract to the systemic circulation. And it can include dissolution of drug. There can be variability in its absorption across the small intestine mucosa due to differences in the expression of drug metabolizing enzymes and transporters in the epithelial cells. There can be differences in the extent of drug that then makes the first passage across the liver due to inter-individual differences in the expression and activity of enzymes that metabolize that drug within the liver. For tacrolimus, the fraction of the dose that actually makes it into the systemic circulation averages about 25%, but can vary between 5 and 95% between patients. So you can appreciate the need for therapeutic drug monitoring. So this is Pharmacology 101 in 30 seconds. So for most drugs, their concentrations in plasma or blood will increase rapidly during the absorption phase, and then once that is complete, they will decline with time as drug is cleared by the liver. Consequently, the pharmacological effects usually also increase rapidly in the early post-dose period and then reach their maximal intensity, coinciding usually with maximum drug concentrations in plasma, and also pharmacological effect will decline with time as the drug is cleared. In reality, patient concentration versus time curves don't look this neat. They usually look like this mess over here. There's often variability in the plasma concentration time curve and differences between individuals. This isn't necessarily a problem when a drug has a wide therapeutic window. That is, when the concentrations or doses that produce the desired pharmacological effect are much lower than the concentrations that produce off-target effects or toxicity. However, for drugs with a narrow therapeutic index, it's important that this pharmacokinetic variability is addressed. So our lab carries out therapeutic drug monitoring of these drugs that are essential and that have a narrow therapeutic window. We're a NATA accredited laboratory, so we work to Australian standard ISO 15189, which sets out the requirements for quality and competence in medical laboratories. Now, we monitor immunosuppressants that are used for transplantation, and this includes cyclosporin, tacrolimus, sirolimus, everolimus, and mycophenolic acid. And we support transplantation in South Australia at the RA, at Flinders Medical Centre and Women's and Children's Hospital, and also interstate, particularly in the Northern Territory, Queensland, and Tasmania. We also monitor the myocardial metabolic agent perhexylene that's used to treat ischemic heart disease, the anticonvulsant lamotrigine, and most recently, we've begun monitoring kinase inhibitors, imatinib, sunitinib, erlotinib, gefitinib, and pazopanib, which are cancer chemotherapeutic agents. And I'm sure Paul will talk more about those. So we're located at the Basil Hetzel Institute, across the road from the Queen Elizabeth Hospital. Our clinical service staff includes 1 medical scientist and 4 technical officers, but we also have research staff and higher degree students that have been externally funded by NHMIC, Cancer Council, and Heart Foundation. So at Heart, we're an analytical chemistry laboratory. And the analytical platform that we use most is chromatography coupled to tandem mass spectrometry or coupled to ultraviolet or fluorescence detection. And all of these are highly specific and sensitive methods for the detection of drugs or other substances in biological fluids. So we not only provide direct patient care service, but we also carry out research to better understand mechanisms that underlie variability in drug response in order to improve both drug use and patient care. So now I thought I'd really quickly run through 4 examples of the sorts of research projects that we carry out to complement our therapeutic drug monitoring service. This is a project that we're working on at the moment, and we are collaborating on a randomized controlled trial of perhexylene for the treatment of hypertrophic cardiomyopathy. And if successful, this would be a new indication for perhexylene. So we are carrying out all of the blinded monitoring for patients in this trial, and then giving dosage adjustment advice for both active and placebo patients. Now, perhexylene is an important drug to monitor because it can cause hepatotoxicity and peripheral neuropathy, and the dosage requirements between individuals can vary quite substantially. You can see this in this drug. These are plasma concentration versus time curves for 2 patients that we have previously studied in our laboratory. Most patients who take perhexylene require 100 milligrams twice a day to attain plasma concentration within the recommended therapeutic range. You can see the concentrations rise and fall within the 12-hour dosing interval. However, about 6% of Caucasians carry genetic mutations in the enzyme that metabolizes perhexylene, and so their ability to clear perhexylene is significantly impaired. These patients only need 100 milligrams once a week to achieve the same plasma concentration range. So treatment for them is very cheap, but you can appreciate the need to carefully monitor perhexylene concentrations and adjust dose. This is a study we've just completed. It was a multi-center study looking at a significant drug interaction between one of the immunosuppressants, mycophenolic acid, and pantoprazole, which is a proton pump inhibitor often prescribed to transplant patients for the treatment of peptic ulcer disease. And we showed in this study that the interaction with pantoprazole was different depending on which formulation of mycophenolic acid patients were taking. For example, patients who were taking the prodrug formulation of mycophenolic acid, mycophenolate mofetil, in these patients, if they were administered pantoprazole, their plasma exposure was significantly lower than when they were administered placebo. So co-administration of pantoprazole may increase the risk of rejection in patients taking mycophenolate mofetil. In contrast, if patients were taking the enteric-coated formulation of mycophenolic acid, the interaction was smaller but was in the opposite direction. In this case, when patients were co-administered pantoprazole, their exposure was slightly higher than if they were co-administered placebo. So this highlights how drug interactions may differ depending on the formulations of the drugs. It highlights the importance of therapeutic drug monitoring in picking up these interactions and maintaining safety. We've also taken advantage of the really high specificity and selectivity of tandem mass spectrometry to look at if there are any advantages in monitoring immunosuppressants in matrices other than blood. So we were able to measure mycophenolic acid concentrations in peripheral blood mononuclear cells in transplant patients. PBMCs are enriched in lymphocytes, which are the cells that mediate rejection. And this study showed that if we measured mycophenolic acid concentrations in PBMC, we were better able to predict the risk of rejection than the current use of measuring plasma concentrations of mycophenolic acid. We've applied a similar mindset and have used mass spectrometry to measure the immunosuppressant Tacrolimus in tiny pieces of allograft biopsy samples in renal transplant patients, and have shown that there isn't a very good correlation between Tacrolimus concentrations in blood and Tacrolimus concentration in the transplanted kidney, but the risk of acute nephrotoxicity caused by Tacrolimus appears to be related to high exposures within the transplanted organ. So I'll stop now, or Paul won't have any time to talk. These are my contact details if anyone thinks that we could help you with research studies, and I'll link on the Basil Hetzel website. Thank you.
Great, thank you very much, Betty. We might just go straight over to Paul, and then if there's any questions, we can deal with any Q&A at the end. He's going to expand on just one of the things that Betty talked about, and that is the recently developing therapeutic drug monitoring of kinase inhibitors used in cancer patients in routine oncology.
Thanks for the introduction. All right, so I'm just going to give a very brief overview of therapeutic drug monitoring in this field of oncology treatment. It's not often that we see TDM done in oncology. It's actually it's gaining a lot of traction overseas and even interstate. This is really a new service for South Australia, and I'll just go through what the advantages are and where this could be used. To start with, why TDM in oncology? Well, we use TDM when it's helpful with drugs that have narrow therapeutic ranges and narrow indexes where there's efficacy and toxicity is proportional to the drug plasma concentration. This is an example of precision medicine where we're, instead of going by fixed dosing for every individual, we're looking at precisely tailoring that drug for that particular individual based on a whole number of variabilities that I'll just quickly touch on. It also has a component of translational medicine involved, especially when TDM is combined with pharmacodynamic modelling together with pharmacokinetic modelling. So if we were to look at just a very simple explanation of how TDM works, what we've got here is the drug plasma concentration. So when you take pharmacokinetic samples, this is really what you're taking over time, the concentration of that drug in your plasma sample over time. And what we have here is steady state after 5 doses. So this is steady state here where an equilibrium is reached due to accumulation over time. And this is based on 5 half-lives. So the key part to point out here that if we look at the therapeutic window, what that means is that at the top end of the therapeutic margin, we have that ceiling of toxicity. So if we hit that ceiling, that's when we start seeing toxic effects, and the risk-benefit profile of that drug becomes a little bit more towards the risk side. If we then look at the lower end, and it's the minimum concentration that we start seeing efficacy. And again, this is where the risk-benefit really needs to be above this line. And this is actually just as much of a risk for oncology patients as having toxicity. In fact, with clinical trials, one of the worst things that we fear about is underdosing, where we're dosing well below this minimum effective level, because what that produces with underdosing is disease progression, treatment failure, and also we know that by underdosing, we can also induce resistance. We know that having targeted therapies at the correct therapeutic window where the receptors are all occupied or all targeted by that therapy, that the resistance mechanisms are reduced. And so it also leads to, in the clinical trial space, as well as the therapeutic space, a failure of a very good potential therapeutic agent due to something that could be easily prevented just by application of pharmacokinetics. So on the top end, we have overdosing. So this is where, as I mentioned, the top end of the toxicity ceiling, where we would see side effects. What those side effects lead to serious adverse events. We also know that a number of hospitalizations from oncology, hematology patients are drug-related, and on occasion, deaths have occurred. But one often overlooked, I guess, issue with overdosing is the quality of life issue. With patients that have very low reserves, having something such as nausea and vomiting affecting their quality of life can then lead to poor compliance and poor adherence, and often patients can't tolerate the treatment based on the toxic effects of that particular agent. So this is why tyrosine kinase inhibitors, for example, fit this model. Because if we look at the purpose of TDM, it's really to measure this drug concentration in the blood in order to adapt the dosage. So it's really an active measurement. We're measuring it to do something in return. We often see it used in antibiotics such as vancomycin, cardiology such as perhexalin levels at QEH, and immunosuppressants such as Tacrolimus and multiple others. In reality, what we measure is the plasma trough concentration, which is commonly used. This is the residual concentration taken pre-dose prior to the dose being given. The reason we do that is because it's less complex and it's less expensive. Ideally, you'd want to be able to take pharmacokinetic samples throughout the whole entire 12 to 24 hours and do a proper pharmacokinetic and pharmacodynamic model, but that obviously is inconvenient for patients and expensive. What makes tyrosine kinase inhibitors suitable for TDM, as I explained, they have a very narrow therapeutic index between efficacy and toxicity. So the reason that is because even though with the name targeted therapies, they're targeted because they're very specific. They have specific binding towards their on-target receptors or their on-target effects. If you overdose or have it outside of that therapeutic index, what you can often have is secondary off-target effects. And that's where targeted therapies become non-targeted therapies. And it's all around that narrow therapeutic index. So this is why TDM is very suited for tyrosine kinase inhibitors with such a narrow index. There's also significant inter-individual variability that affects bioavailability and metabolism. And just a very brief summary of these. So genetic polymorphisms are a great example where we see slow versus fast metabolizers. We know that a lot of the tyrosine kinase inhibitors have significant drug-drug interactions. In fact, this is where probably most of the side effects are occurring, because we know that oncology and hematology patients are on multiple medications that have polypharmacy, and there's a whole slew of complicated drug-drug interactions, and that's not even taken into consideration all the transporter effects and other effects that could be causing an interaction here. There's also physiological with age changes, pathological with renal failure, liver failure, and intercurrent illnesses, and other things such as food effect, which can significantly affect absorption and pharmacokinetics. Even using pantoprazole or PPI inhibitors in certain medications can affect absorption and pharmacokinetics and the therapeutic index based on that drug. So Other characteristics for TDM that are important, and probably this is the key one to highlight, is the dose response. It's one thing to measure a drug and determine whether or not it's within a particular index, but that doesn't really mean much if that index doesn't lead to a clinical outcome. It's almost like saying, if I reduce my cholesterol level, will it decrease heart disease? And likewise with oncology, just by getting it within that therapeutic window, does that really mean this cancer patient or hematological patient will have a better outcome in their disease? So the way that we then look at this from a TKI, TDM perspective is looking at evidence-based clinical trials. So observational PK studies, pharmacodynamic PK relationship analysis, and a whole slew of randomized clinical control studies and also reviews. There's significant data being accumulated in the space overseas. And what we're looking for are validated outcomes. What that means is that dose response for that drug shows that disease will improve. And I'll give a very brief example of that in a short while. Anything that falls outside of that becomes an exploratory endpoint. We can still use this, but it then enters more the realm of phase 1 or phase 2 clinical trials. The other thing that is a characteristic for TDM is an appropriate quantification method. So mass spectrometry is ideal for this because we know that tyrosine kinase inhibitors are either used by themselves or in combination. So being able to analyze them in combination is very important. We also know that mass spectrometry can go down to extreme low levels. And a good example of this is measuring CSF fluid for a kinase inhibitor that crosses the blood-brain barrier. I'll skip through this slide actually, just for the interest of time. I just wanted to point out where this fits in terms of all of oncology. So we've got cytotoxics. We often wonder why is there no TDM within cytotoxics? Well, it comes back to that dose response. We know that it's less targeted with cytotoxics, it affects all cells, and we don't understand fully what that response would be in terms of clinical outcomes. So there's much less validation, mainly because of the pharmacodynamic measures are too broad. Immunotherapy, even more difficult, also has a very large therapeutic index. We know we can dose quite high, but I guess the benefit with TDM with immunotherapy then becomes more of a financial and more of a dosing issue. Rather than having such increased dosing frequencies, we can sometimes reduce them based on pharmacokinetics. And obviously there's a whole slew of other novel and not so novel therapies where TDM is particularly relevant and some that wouldn't be relevant. So I'll give a very quick example. The reason I've picked imatinib is because it's the oldest tyrosine kinase. So in this example, we know that imatinib, as it's used for CML, can have a high non-adherence for a number of reasons. It has, again, those quality of life side effects of nausea and vomiting. I guess also the other thing that increases its non-adherence is it can be a chronic treatment rather than 6 months. We know that low trough concentrations can relate to molecular response correlation. It's also used within oncology for GIST. So based on its mechanism, we've got a pharmacodynamic marker as well of working out is it effective? And by blocking this protein, translates to a clinical outcome, and that's decreased proliferation and increased apoptosis. So what we've seen here, several studies have shown, actually just to summarize this instead of going into significant detail, the key point here is that several studies have showed that over 24 months of using imatinib with the pharmacokinetics being analysed for this purpose, that we see a 60% of cytogenic response and a 50% complete remission. That means is that almost half of the population by 24 months are not getting a cytogenic response. They're not getting complete remission. And look, that could be for other factors such as mutations and resistance and a variety of other things. But we know that based on this study that significant proportion are underdosed and not within that therapeutic margin. So what they've determined is in order to get cytogenic response and complete remission, you really need to set that trough level above 1,000 nanograms per mil, and this is associated with that response. Any higher than 3,000 though, that's when you start getting side effects of toxicity. So I think this is a really nice, simple example of where we're seeing pharmacokinetics used and based on that individual patient and determining effects, and also increasing that chance of efficacy for patients as well. Just very quickly, this is a really nice slide just showing the power of pharmacology, where we're using a combination of pharmacogenomics and also pharmacokinetics to tailor responses and increase efficacy and reduce wastage by ensuring that that patient gets the best chance of response rather than just throwing any therapy at patients. I'll just reference a really nice paper here that just shows you the variability of within certain studies of how much the population were underdosed that were below that therapeutic level. And here we have 85%, for example. So just very quickly, I've almost towards the end of my presentation, when will we use this then? So we would commonly use this when we're suspicious of a therapeutic failure. If you're suspicious of adherence issues, if you think that there's a low dose and it's translated to a very poor response when there should otherwise be suspected response. If there's a risk of variability, polypharmacy, patient characteristics, as I've already covered, or if there's an unusual adverse toxic effect due to a suspected excessive dose. One of the key parts is interpretation. It's an important part. It's a very complicated patient group, so it requires a little bit of knowledge of clinical data, some pharmacokinetics and pharmacodynamics. We also have to make sure that the precise collection time is taken, and also an understanding of what else is being co-administered. That being said, the people to contact with those types of questions would be Dr. Ganesan Kichinadasi, who's a medical oncologist and clinical pharmacologist, and really has championed this new service, and Betty as the leader of the mass spectrometry lab. And of course, you can contact me as well with any clinical pharmacology or dosing questions. So to summarize, basically, I think that TDM is a good thing for oncology patients. There's a significant amount of evidence that shows the benefit patients potentially have, especially when there's a known validated relationship between exposure and response. It also allows the physician to adjust their dose based on those pharmacokinetic targets and reduce side effects. And that's the end of Sephr. Thank you.
Excellent. Thank you very much, Paul. We just do have a couple of minutes for Q&A. So if you do have any questions, please take the opportunity to ask. I wanted to go back to Betty, if you're still there, and if you can unmute yourself in response. Obviously across the biomedical precinct, there'll be lots of individuals who are interested in novel drugs. If they're interested in doing an assay of that, what would be the steps involved? Can you sort of talk us through in terms of how long that might take to get set up?
I guess it really depends on the compound that's been asked to be measured. Often we can set up in, say, 3 to 6 months if we can work full time on a project. But if we are needing to pull someone off clinical service, maybe 1 day a week, then that can spread out to a longer period. So it all depends on how well resourced we are. But mass spectrometry and chromatography is such a versatile analytical platform that you can basically set up an assay for any small compound that you want to, really, given enough time and enough resources.
So it's more about, so your staff have got the capability to be able to do it. It's more about just having the resourcing to be able to make it possible.
That's right. So any small compound is possible. Yeah.
There's another question here for Paul. So we've had evidence for the benefit of TDM in oncology, including older oncology drugs such as 5-FU for some time, but seen little uptake in routine clinical practice. Why do you think this is the case? And can you also talk about, where you see the TDM for TKI at the moment? Would you say it is routine practice, or is it still at the research level? Do you want to sort of, talk about that a little bit?
Yeah, sure. Sort of back to answer that question with the 5-FU. So there is actually a really interesting paper on FOLFIRI, which involves obviously 5-FU for colorectal patients, where they're using TDM and have validated its dose response effects. I think the slow uptake is purely based on expense. With mass spectrometers, you have to have a lab that has a validated process, and the quantitation and all the setup costs are quite significant. And I guess that's one of luxuries we've had with this group. They've had funding to be able to set that up. So FOLFIRI is a great example where potentially in the near future that might be added to the list, because you're right, there's validated data that shows that that one would be very appropriate for TDM and potentially would have uptake because it's quite relevant, even though it is an older drug. And then the second question, Sephr, was research setting. So interestingly, this is not done in South Australia, probably for the reasons that I just mentioned. It's expensive and there's no lab that's been set up until now with Betty's lab. So it's gone beyond that research stage where, correct me if I'm wrong, Betty, that it's being set up so people can start ordering levels for their patients if they suspect toxicity or underdosing. And those methods are using validated pharmacokinetic models using population pharmacokinetics. So they go back to that paper that I referenced where there's a group of studies showing that validated dose response shows clinical outcomes of benefit versus experimental endpoints. So I think Sephr, it's at the stage where it's ready to be used therapeutically, but it's not commonly used in Australia. It's more commonly used overseas in Europe and especially in the US, and very much so in clinical trials.
Okay, thank you very much. I'd just like to take the opportunity to thank our two presenters today on the role of therapeutic drug monitoring and potentially what can be provided in the future in terms of sort of novel areas regarding cancer. And a reminder that next week's session will be on imaging, with presenters Chris Christou and Professor Steve Wessling on behalf of Andrew Dwyer, with Professor Wessling also being the chair. So thank you very much, everyone, for your involvement today, and look forward to seeing you next week.